So get those minimized, I'll give you the mouse.
Cool. Alright guys, I'm Alex Cheatham, I'm the EMS fellow this year. Hopefully saw some of you last month virtually, and I'm excited to kind of be running CQI this month. So we have a couple of good cases or a couple of themes through some of last month's cases. So hopefully there's interesting information and some good learning. I want to start off by just saying that this is my first time reviewing your guys' charts, and I was really impressed by your documentation. I always feel like if I can understand why things were done or what someone's thought process was, that really means that you've done a good job. And it was super clear to me in the charts that I had to review kind of your rationale behind treatment decisions. You really delineated your thought processes clearly. There were descriptions. So in one case, why there was a delay to care in terms of sort of factors outside of your control. Very often there's documentation of how exam findings changed or progressed over the course of a patient's time with you, even if it's a short transport. It was really great to see. And then also some descriptions of kind of aspects of the scene that maybe impacted patient care, and kind of why or how that affected your care. So just want to say that I was super impressed, and really appreciate your kind of attention to documentation in these cases. So we're going to start and go through a couple of seizure cases. The first, and then highlighted in yellow, is kind of physical exam, and green is either things that you guys did or other kind of good information that was included. So 72-year-old with seizures, patient was found laying supine in the bathroom, alert and oriented. He thinks nothing's wrong. His wife said he had 2 seizures. And then again, he says he feels fine, but he's unable to sit up or control his left side. When asked if he can look at the medics, he kept his head turned to the right, but thought he was looking forward. He has a history of seizures and no allergies, and his wife said his last known normal was about 10 p.m. Again, he was found laying supine. He had a facial droop, but his speech was good. When he sat up, he couldn't control his posture. I thought that was a really great addition to this. Not something we often think about, but really a good physical exam finding. And the patient was unable to lift his left arm for a grip or an arm drift and couldn't follow with his eyes. He got a blood glucose, which was normal. Got a couple other things, including a 12 lead, which looked okay, and other vital signs that were normal. And just prior to arrival to the hospital, he started to move his left arm. And at that point, he got the stroke scale. He did not have any drift, and he was able to grip equally on both sides, able to follow with his eyes at that point. And whatever symptoms he was presenting with seemed to have resolved. Other than that, took him to Westchester, gave reports, and handed the patient off to the hospital team. So learning points for this case, I think you had great recognition of the fact that these were possible stroke symptoms and appropriately transferred to a stroke center. That'll be important as we look at the next case. And again, really great documentation of kind of what the symptoms were, how they progressed, how they evolved in the patient's time with you. And so I just wanted to go through a couple of sort of differential diagnoses to think about when a patient has self-resolving neurologic symptoms. So obviously stroke is at the top, but a transient ischemic attack is by definition stroke symptoms that resolve, hence why it's transient. Todd's paralysis is another interesting phenomenon. So patients with seizures, after their seizure is done, can actually have full-on paralysis or sort of milder paresis of one side of their body, one limb. And it can last minutes or it can actually last days. And this is sort of a known issue with seizures, and actually happens in up to 15% of seizures, which I thought was a lot higher than before I had looked it up a little bit more. Complex migraine can give you paralysis on one side of your body, and then obviously hypoglycemia is a common mimic of stroke-like symptoms, which you guys appropriately got the sugar actually in all of these cases. And so just thinking of other things that might have been going on with this patient, but the point is that you always are safest to assume that it's stroke, always safest to take the patient to a stroke center, and to be quick and expedite your workup of the patient. So overall, I think this was, again, great documentation and an example of some interesting kind of seizure or stroke findings. Any comments?
No, I think the differential there is key, right? In terms of assuming that it's gonna end up being stroke, but the reality is that like 100% you're gonna have attached paralysis. And I think the question might be is like with a prior history, or at least like the scene history of like seizure-like activity, and then you're seeing what you're seeing, like do you end up getting some benzodiazepines just to get it balanced out a little bit? I think probably where we thread the needle here with, especially with like improving symptoms, you know, hurry up, we well enough alone, I think it's probably the right thing to do in this particular situation. As long as, you know, good handoff with kind of what they saw in the scene prior to that.
So from the hospital, the patient was recommended for admission for neuro and a cardiac workup. Patient had elevated troponins in the ED. He refused all workups and admission, and he wanted to follow up with his neurologist. He was advised of the risk and was discharged, which I think leads us into case 2.
Yep. So here we go again. So this is case 2, but not so much. It's just a different shift and a different crew, but it's the same patient. So same 72-year-old man with known seizures. You were told, at least at dispatch, that he had been in the hospital earlier this morning, but kind of more information comes later. When you find him, he's sitting in his chair with concern of seizures, but the patient is completely unresponsive. He's snoring, has a GCS of 3. At this point, the wife is yelling at you, which is not particularly helpful, and tells you that they were seen at Westchester, told that they should have been monitored, but left and only want to go to B North. And the previous crew had decided to take the patient to Westchester, like we talked about, appropriately because of stroke-like symptoms. The additional kind of history here is that the patient has known seizures and that he's just changed his seizure medication. So that was sort of like an additional piece of information that maybe hadn't, or at least wasn't documented with the first time the patient was seen. So this time, the patient's in a very different situation. So again, the patient's not responsive, glucose is 111, so that's fine. And then while you're evaluating him, he begins to have another seizure. You go to drop the meds, but while you're drawing them up, the patient stops seizing, but was still unresponsive. You got him lifted up and tried to address his kind of snoring respirations with a head tilt chin lift, but that didn't change his breathing very much. You got him exposed, got an EKG, which showed sinus tach, put on N-tidal and some oxygen, and SATs were 95%. At that point, the patient starts seizing again. You've got your meds pulled up that you already got when he was seizing the first time, and he got 10 milligrams of Versed intramuscular, and at that point, the seizure stopped. But his pulse ox is 93%, he's still snoring, so you bag him with 15 liters of oxygen, reposition him, and although you still have kind of noisy breathing, you're then able to get good compliance and get SATs up to 99%. And at that point, kind of tie him up in a nice little bow and get him moved to over to B North, which is what the family had requested. So again, getting a blood glucose for these patients with altered mental status, honestly, is often forgotten on the hospital side, so incredibly important. And again, for this patient, it was normal. For him, you had great documentation of kind of the indication for your Versed, which was actually clustering of seizures. So usually the indication is a seizure lasting more than 5 minutes, but if a patient is having repeated seizures and is not coming back to baseline in the middle, then that is another indication to give a benzodiazepine. So that was clearly documented. And then the respiratory assessment in this case, which sounds like it was a little bit challenging. There are a lot of reasons why a seizing patient may not be breathing well. One, they might have some other problem or have obstructive sleep apnea at baseline. They may actually not have good respiratory drive, Or if you or the family has already given benzos, then obviously that's gonna decrease their respiratory drive. So documenting and getting in title, documenting that the airway was obstructed and really what you had to do and how the patient responded to your interventions was really, really well done in this case. And then the final thing is like, how do you manage a patient or family who is upset or frustrated? I would say, yes, the patient was informed of the risks of leaving Westchester earlier in the day. Clearly it was a risky move, and he ended up in probably a worse situation by the time he got there the second time. And it's incredibly, incredibly difficult to talk folks down or deal with that while you're also trying to deal with a obtunded, unresponsive patient. So it's hard to know kind of what conversations happened. You did document that you told the family, like, we'll take you to B North, but only if he's stable enough to go there, and you did get him to a decent spot. So I think it was reasonable. But obviously, if the patient is super unstable and you can't abide by those wishes, you go where you need to go. And so I thought that was thoughtfully done in this case. Hopefully you have enough people that you can kind of assign someone the task of dealing with that family member. That's usually what I find is most helpful. But I just wanted to touch on the fact that this made this case a little bit more challenging than it needed to. So hospital follow-up or other comments on him the second time?
Unfortunately, it sent the patient to be north, I couldn't see it, but.
No, I 100% agree with those learning points. I mean, especially, that situation, there was some pretty active management in the back, but like, I spent like 15 minutes trying to convince them to go to like Westchester versus like B North, because it's like, I don't know exactly where the township this happened, but clearly the fastest way those patients can get to the hospital is for us to just go to B North, and especially if they're ready to like that interaction maybe wasn't super favorable, or they had a medical home or some clear preference for like, they even had left AMA earlier in the day to be like, yeah, what's going over there? I think certainly very appropriate, and I'm glad you guys, kept that medical home in mind when you were thinking about that. Here we had definitely, I agree with you, a very hard indication for benzodiazepines this time.
Yeah.
I agree. That first time, I don't know what I would have. So some of the department, they certainly do prescribe it as kind of like a go home kind of thing, but I wouldn't be surprised if we did not get that from that first visit either.
Okay, so we'll move on to case 3. This is the last of the seizure cases. So this is a 34-year-old female with seizures. On arrival, she's inside the bedroom, supine on the bed and actively seizing. Documented as kind of full body seizures that lasted for about 10 seconds after the team arrived. The seizures would stop and continue at random and were lasting 5 to 10 seconds each. Patient's eyes were rolled back, and the patient was breathing at 14 times a minute. Skin was warm and dry. Inside the home and in the bedroom, access was tight, especially in the bedroom. The bed was covered with random items. The bedroom floor had limited access for patient care. And so we planned out patient movements, but in the meantime, got a blood glucose, which was 85. So there's nothing that you have to kind of urgently intervene on there, which is great. Once you can assess them, patient's pupils are equal and reactive, strong pulse, regular pulse, and a stat of 100% in room air. The patient's mother does say that the patient has a history of non-epileptic seizures. It's unknown exactly how many seizures they've had. You got IV access and gave 5 milligrams of Versed via IV, and about 30 seconds after the initial dose, patient's eyes opened, able to communicate right away. The patient had no signs of a post-ictal state and was able to answer all of our questions appropriately. That's phenomenal documentation and really helps to kind of drive home the point of probably what was happening for this patient. That your response to Versed was maybe a little different than what you usually see or experience with generalized tonic-clonic seizures. While en route, the patient had no more seizure activity, was able to communicate with you totally normally. And when you started the process of taking off all of your equipment and moving the patient to the ER stretcher, the patient started having another seizure. You had the rest of the Versed file ready, so went to give it, she ended up getting about 3 milligrams just because some of it was kind of knocked out of your hand. So learning points again, blood glucose, which I already touched on, was fantastic, and then sort of thinking about non-epileptic spells, which are also called pseudo seizures. Medically, we like to call them non-epileptic spells, but a lot of families might still use that, the older term of pseudo seizures. And again, for this, it's always reasonable to err on the side of treating the patient. You guys have limited information, you have limited time, and if someone looks like they may be seizing, or a family member is concerned they're seizing, and she was seizing when you got there, which is an indication to sort of basically an assumption that this is status, and then had additional small seizures, it's absolutely reasonable, in my opinion, to go ahead and treat with Versed. I have a couple of videos, and you guys probably have seen real seizures and non-epileptic spells before, but they can at times be hard to tell apart. And if you are on the fence or are concerned, then I would err on the side of treating. You know, advise the patient some more time in the ER. Sometimes they get more meds, but if it's a true seizure and it's continuing past 5 minutes, 10 minutes, 15 minutes, then the risk to that patient is, you know, potentially long-term neurologic damage. So you're trying to avoid the worst, even if you're treating some cases that aren't necessarily going to be real. And these are tough. They're really difficult, depending on the buy-in of the family, their knowledge of their history, and what the spells look like. They can be really, really difficult to tease apart and to manage.
Yeah, I 100% agree. I mean, if you come up on seizure-like activity, the downside of giving benzodiazepine is far outweighed by the downside of not giving benzodiazepine to true seizures. And it's not uncommon. I mean, certainly there are patients who have had true epileptic, or at least had a diagnosis of epileptic seizures, who also have non-epileptic spells. And so, I mean, you're not going to be able to like differentiate between the two. If you end up letting a true seizure ride, like that's a far greater problem than giving benzodiazepine with seizure activity. Yeah, it's also important to recognize. I mean, it's not like these patients are like faking it. It is a non-epileptic pathology. Yes, it maybe responds to like a stressful environment or these sort of things. And you can actually sometimes coach them out of it. You can say like, you know, Jane, like stop that, we're here, you can take deep breaths, go ahead and stop that. Sometimes it actually doesn't work. But it is not like oh, I'm going to just like shake my body kind of thing. It's it's not a conscious thing that they're doing. And so treating them with respect and all the rest is obviously really important. You guys always do that, but erring on the side of treating like an epileptic when you don't really know the difference, it's really reasonable. Sometimes in my documentation I write seizure-like activity. If it's very unclear, or if it's pretty clear that this is another pseudo seizure, but that nuanced documentation really doesn't make a huge difference. I just have to pick that up on the documentation.
Yeah, so she only had one other episode in the ER. The MD came in the room to assess her. She started with some back arching and some extremity movement. He unfortunately stepped out of the room to take an emergent call, and when she came back, she was into the room. She was completely alert and oriented, and she stated that it felt like one of her non-epileptic events. She returned completely to baseline, and she was discharged home.
If you come on scene and the activity has stopped, your assessment of that post-ictal state is super important in differentiation as well. So you've all seen true post-ictal states before. You see people with non-epileptic form doing their movements and then right back through it, they're talking to you. And so communicating that difference can sometimes be a huge differentiating in terms of diagnosis of eventual disposition.
Yeah. Another clue can be kind of the ability to hold tone, so someone who is having an epileptic seizure that starts in a chair, for example, is gonna fall off that chair. But in non-epileptic spells, often they can kind of maintain some tone and avoid that, those kind of like more significant injuries or falls, despite what's happening, so. Because no one likes to hear one person talk the whole time, I'm gonna show a couple of videos if they work. So this is a patient with a generalized tonic-clonic seizure. Let's see if I can. We'll just watch, 10, 15 frames. So it's drawing, contracting. Little miniature fire bread we did to the farm. It's fire bread and it's it's a like a gear. Sorry, it's burning. It's a big it makes all kinds of So this is a seizure that started out focal on that right side, and then generalizes to full body generalized tonic-clonic jerking, and obviously is pretty impressive in terms of like that stiffening, altered mental status, and all the rest of it. This is, by contrast, the patient with non-epileptic spells. So talking and interacting. You start to see like the right hand is jerking. And although in some ways you might call it rhythmic movements, so although some parts of this are sort of rhythmic movements of the head or the extremity, it's much more kind of like disorganized. Again, the patient is maintaining some amount of tone to kind of stay on the couch at one point. She sort of rolls over but stays there. And so just an example of a non-epileptic spell. And obviously if someone who doesn't know the patient, or it's the first time the patient is having these, and the person observing has no medical training, like this absolutely will look like a seizure, and the person can be totally unresponsive during them. And so again, they can still be difficult to tease apart, but I just wanted to give you guys that kind of comparison. And then the final thing that I want to show you, which we'll kind of talk about some of the other thoughts when you're evaluating a patient with seizures. This is probably my favorite thing to Google when I see patients with syncope who have kind of like post-syncopal abnormal movements that the bystander thought was a seizure. So I routinely pull this up on shifts and show patients, I don't know, for what that's worth. So these are healthy students that they had hyperventilate and squat, and then had them stand up very quickly, basically making them syncopize, and then they just recorded what happened after the fact. And some of the movements that they have after their syncopal episode look very much like seizure. And so again, something that can be confused for seizure, especially by a bystander. So he's gonna go down. So that jerking, twitching. I think the next one's pretty good too. So twitches, jerks that look very much like, yes, they were brief, but can look very much like seizure. And so people can get confused by that as well. So some pearls around seizures, they can present a lot of different ways. Different types of seizures will look different. So simple partial seizures, patients actually have maintained consciousness and they're usually asymmetrical. Complex partial seizures, the patient is not aware of their environment or maybe unconscious, and they have kind of purposeless movements, usually like picking or grabbing type of movements. And then generalized, or what we're most familiar with and what we see most often, they're often associated with apnea or some sort of airway compromise, and are often associated by a postictal state, which Dr. Richards talked about. Status is one seizure lasting more than 5 minutes, or one seizure, or more than one seizure without a lucid interval in between. So if they don't go back to baseline between repeated seizures, that would be clustering. And from an EMS perspective, if someone is seizing when you arrive, then you have to consider that patient to be in status. Thought being, if it started before you got there and it's still going on, it's probably been more than 5 minutes, basically. An evaluation, blood glucose, I don't feel like I have to tell you to do that because you did it in all these cases, and obviously act on it if it's abnormal. Look for signs of trauma or intoxication. An EKG can be helpful, which you got for all three. I can't remember now for the 32-year-old, but you got an EKG both times for the old guy. So first time seizure in patients over 50 can absolutely be cardiac. Or if the people on scene, just watch them go down and then they have these abnormal movements, that could be syncope rather than seizure. So an EKG can be very helpful. And then if the person's obviously pregnant, then definitely think about eclampsia, which is a medical emergency. And then finally, your management is Versed by whatever route you want to give it. Obviously, IM is easy if someone is unconscious or actively moving and it's difficult to get an IV. And then just be really careful to monitor their breathing and have a really low threshold to support them with bag bell mask ventilations, especially after you've given Versed, but even during the seizure, right? They have lots of different reasons to be apneic, lots of different reasons to have a compromised airway. So have a really low threshold to support them. And tidal, like in the first case, can be very helpful. Sorry, the second case can be very helpful if you're not sure how good their respiratory drive has been or how long they've been down. But when in doubt, go ahead and bag them. So that's the end of my seizure cases. Any questions about those?
One thing that does come to mind is with the partial seizures, you mentioned this, but like they very well may have preserved consciousness and talking to you and have just like this weird movement or even weakness or vocal rhythmic movements of like something looks very odd, but they may have that preserved mental status and talk to you. And I think something sorting out exactly what that really ends up being, and our secret things on that list. So, and of course, we'd be remiss if not taking the opportunity to obviously high index suspicion for cardiac arrest that gets dispatched out as like seizure and OS, which leads someone who has not had it before, and even by the time you roll back over, probably they will have probably declared himself by then, but it's usually more on the dispatch side of things. Seizure like activity, yeah, this gotta always good to remind ourselves that's presented.
Great, thank you so much. We're going to veer away entirely from the neurologic system and just talk about a case of anaphylaxis. This case highlights the fact that you guys did everything you were supposed to do, but I think has a couple of interesting points and was true anaphylactic shock, which we don't see all that often. So this is a 4-year-old with an allergic reaction. He's on the garage floor, sweating profusely. His coworkers said that he was replacing a roof when he got stung by several bees on the calves, started to feel very hot, dizzy, and lightheaded. Thankfully, he didn't fall off the roof. Somehow they got him down, seems like. But shortly after that, he felt too weak to stand and was laid on the ground. He is unsure if he has an allergic reaction to bee stings and has no other medical history. Denies trouble breathing, and his lung sounds are clear, but his blood pressure is 70/40. He's defecated on himself. He can barely walk and had barely any strength to move or stand. He was assisted to the cot, placed on 4 liters of oxygen via nasal cannula, got an IV in the right AC, got a 500 cc fluid bolus through the IV, got 0.3 milligrams of 1 to 1000 epi-IM, and also got 50 milligrams of Benadryl through the IV. After this, he improved greatly and was ANO ×4 with a GCS of 15 after medication administration. His skin went from hot and very sweaty to warm and slightly sweaty. He had no other complaints, but still was lightheaded and had a new headache. He has no signs of injury, which again, I think is great to document that. Lung sounds were clear throughout transport. And he stated many times that he felt a lot better, and that he was coming back to feeling like himself. So again, you guys, I think, met all of the major management priorities for this patient for anaphylactic shock. And so did a fantastic job, and I think the documentation again was great in terms of where the different medications were given. Obviously, IM for anaphylaxis, or sorry, epi for anaphylaxis should be the 1 to 1000 dosing given IM, even if you have an IV. You always give it IM. Benadryl though could be either IM or IV, and so documenting how the meds were given is important and helpful for a case like this. And then I just want to talk through kind of what this patient's presentation was and a little bit about anaphylaxis. So remember that anaphylaxis or allergic reactions are on a spectrum from a relatively mild reaction to true anaphylactic shock, which is a distributive form of shock. So rather than cardiogenic or neurogenic shock, distributive shock is the case with anaphylaxis or sepsis. They kind of all fall into the same bucket. When you're assessing a patient who's having an allergic reaction, I just keep in mind, I'm looking for how many organ systems are affected. And if you have 2 or more organ systems, that's anaphylaxis. And that might be just a rash and some lip swelling, or it might be, full on shock and vomiting or diarrhea, like was the case for this patient. Just because he didn't have major skin findings, or at least you didn't document that he was covered in hives, does not mean that it can't be anaphylaxis. So sometimes I see folks like, well, they don't have a rash, so is it really an allergic reaction? Absolutely. It just has to be any of these organ systems. And if you have hemodynamic instability or any kind of respiratory compromise, then that by definition is anaphylaxis as well. So some of the skin findings might be hives, swelling, itching, warmth, redness, which you documented that he was kind of warm and sweaty, even though he wasn't covered in a rash necessarily. So that was great. Respiratory for this patient, it seems like he was able to get words out, although started to have difficulty, probably more mental status wise with his terrible blood pressure, but that his lungs were clear, that he wasn't hoarse, those sort of things. But coughing, wheezing, difficulty breathing are very, very common in anaphylaxis. The gastrointestinal symptoms can be anything from sort of like spitting a lot, vomiting, to bad stomach pain or cramping, to diarrhea, which is what this patient had. And then cardiovascular, so he was dizzy and lightheaded, he didn't look very good, he had hypotension, and was in shock. And then obviously if your shock state progresses, you become unconscious. So clearly cardiovascular compromise in this case. And then there's neurologic symptoms as well. So anxiety, feeling this kind of impending doom and headache again. So this patient checked off neurologic symptoms, cardiovascular symptoms, GI symptoms, probably not too many respiratory, which is great. And then a little bit of skin as well. And the fact that his blood pressure was low and his mental status was not great put him in this category of anaphylactic shock. When I think of managing anaphylaxis, there's a lot of things you can do. There's really one thing I care about and maybe 2 other things I care about. So epi. If you're worried about this, even if it's 2 systems and they're mild, go ahead and give the IM epi. That's the thing that's going to help you the fastest, and kind of get you the best bang for your buck. And if the symptoms aren't getting better or the symptoms are starting to come back, you can redose that epi every 5 minutes. So IMFE is the mainstay of management for anaphylactic shock. The two other things that can be helpful are certainly fluids for patients who are in shock, and then albuterol for patients who have difficulty breathing, wheezing, or any other respiratory compromise. So those I would say are my kind of three most important things when managing anaphylaxis, because you're really gonna turn that patient around with those different management or with those different meds. The other stuff that can be helpful, Benadryl, which was given in this case, is great, but it's really more of a symptomatic treatment. It's not gonna reverse their shock. So give it to make the patient feel better, but it's not the most important thing on the list. And then other things that we think about in the hospital or that some squads carry would be like steroids or famotidine, which is a type 2 antihistamine. So those are other adjuncts that you might hear about or that other places might use, but again, they help with the symptoms, but they're not going to fix the problem. The things that are going to fix the problem are epi, fluids, and albuterol. So great job managing this case. And then Lauren, did he turn around?
Yeah, you guys basically did everything for this patient. All we did was treat his headache and gave him some steroids. So he was given IV bolus, compazine, prednisone, and Pepcid. He was observed for 4 hours, had no other additional symptoms or events happened. He was prescribed an EpiPen and was discharged home.
Yeah. So really phenomenal. We routinely watch patients for at least 4 hours in the emergency department after the IMFE. So that is just the standard that you'll see for these patients, sometimes a little bit longer. And the reason for that is that patients can have a rebound or a biphasic reaction to their allergic exposure. And so some patients, even though they get better right away and maybe stay better for an hour or two, can then start having symptoms again. And if we have to treat them with IMFE again, then all those patients get admitted. Otherwise, a lot of them can go home. And then the other kind of thing that I didn't put on the slide, but from this case, is that he didn't know that he had an allergy to bee stings, and that's going to be very common. You don't usually get a severe allergic reaction the first time you're exposed to something. So you might have been bitten by or stung by a bee, earlier in his life and not reacted, but this time did. Maybe that was because it was multiple bee stings. Maybe that's because he actually would have had an allergic reaction even to one. But that's very common that people don't know what they're allergic to or that they're allergic to the thing that triggered this event. So kind of don't be fooled just because someone doesn't know.
Yeah, I agree. Epi, if for some reason you feel like you need more than what the protocol, the 5 to 15 minutes IM allows. You do have Pujo's epi in the hypotensive protocol, but if this person's looking in front of you and they're still hypotensive after that IM, I would just get on the phone and see if you're getting more epi in this person. At 54, yes, maybe he has some cardiac disease, but in this situation, epi until they get there. So.
Awesome. Really nice job with this case, guys. All right, and then the last one that we're gonna talk about is a cardiac arrest patient, and that's the last case we have for today. So this is the medics documentation. So by the time they were there, the patient was already on defibrillator pads, being ventilated by valve mask, was confirmed to be in cardiac arrest and placed on the Lucas, and compression started with the Lucas. The patient was defibrillated for the first time with 300 joules. An advanced airway was placed using a size 4 iGel, 18 gauge IV in the right forearm, and the patient was defibrillated with 360 joules at the next pulse check. First round of epi was pushed. Next pulse check still in BFib and defibrillated again with 360 joules. Second round, I skipped the 300 milligrams of amiodarone and then BFib again, and more epi given. And because the patient maintained BFib during the whole time, the decision was made to transport to Westchester Hospital, continuing compressions and continuing to give epi. During patient movement, the IGL was displaced and removed with an intubation attempt, but the intubation attempt failed, and so the IGL was replaced. And got some more epi before arriving at Westchester. At no point did the patient present in any other rhythm besides BFib, except for the less than 10-second bounce of asystole following defibrillation. And when at the hospital, the paramedic became aware of the fact that the epi doses that have been given were given incorrectly because it was the 1 to 1,000 concentration rather than the 1 to 10,000 concentration. They told the medical staff prior to the patient's resuscitation being terminated in ER. Anything other than termination of care?
No, so yeah, he presented a VFib arrest, he was intubated. They did a bedside ultrasound which showed no cardiac activity, and about 40 minutes after his arrest, they called his time of death at 5:25.
So learning points for this case, great job with identifying the rhythm, giving both amio and epi were appropriate. And then identifying that refractory BFib needed to go to the hospital and getting him there. One thought, and this might have been documentation, but just go straight to 360 joules for the first shock. The first shock in this case was documented as 300 joules, but just go straight to that dose of 360. Great job recognizing that the IGL became dislodged. This can be really difficult to recognize during a resuscitation, especially with the Lucas going. You're not getting any kind of manual feedback about chest rise. There's a lot of stuff in the way potentially, but your end tidal can really help in a situation like this. And obviously you can move to a definitive airway, replacing the IGL, repositioning, lots of things you can try. But I think it was reasonable to attempt intubation in this case, and when it was unsuccessful, just go straight back to, what was working before in terms of replacing the IGL. But it can be, I've been fooled by tubes before and by supraglottic devices, so this can be tricky to recognize. So good job recognizing it. And then the one sort of major thing in this case was that there were some challenges with the epi concentration. So like we talked about with the anaphylaxis case, IM, intramuscular epi, should always be 1 to 1,000, but if you're going to give it IV, it should be the 1 to 10,000 or like diluted push dose epi. So I'll let Dr. Richards kind of talk more about that.
Yeah, I mean, on the balance, kind of going through, so of course, it's not a patient that we are going to terminate on scene, right? So there's everything going for a transport, even if it ends up being something that ends up being a reversible cause at the hospital. I agree with you, I like, go big, go home in terms of the first shock. Everything you said about airway management, of course, the entitlement can go on IGL as well. So anytime we're managing invasive airway, whether that's definitive or not, that entitlement certainly goes on, and then having that as a backup, like another IGL backup when it comes to points. The epi concentration is always such a bugaboo, and it really is just so unique to epinephrine. This is obviously a pretty chaotic situation, but any chance you have, just double check, or if a partner asks to double check the medication, please be open to your partner doing that. What we don't do is kind of the double sign off, which for kind of high risk medications in a hospital setting, the nurses all double check. It's technically difficult for us to do that. We always could move to that direction if we really saw an uptick in sorts of challenges. But if you wanted to do that in your regular practice, like I would certainly support you. And if your partner does kind of come to you with that, hey, can you just look at this, double check my epinephrine concentration, please be supportive of that. Like I said, it's hard to do in a scene like this when everyone's really kind of focused on their task, but I'll just support that if it were to come up on your all scenes. When Lauren and Hartley, when So when Andy Hogan was here, we had the case of this. I think, because we've obviously talked about, concentration challenges for cardiac arrest before, but was there any movement or anything like that on the pharmacy side of things when it comes to the concentration issue?
I don't think we had it with, if it was with, 3%, if I remember.
Yeah, that was the last conversation.
Yeah, so no, there's no movement on any changes with like the concentration with epi, like the shortages we're seeing on the boxes and the plastic pieces. So we're still having to stock epi kits.
Yeah.
And I know that's frustrating to everyone, and it's frustrating for our pharmacy staff too. I mean, it takes them hours to fill those bags with those epi kits, so. Whenever we can switch back to boxes, we're going to.
So you don't have the first two jets right now, you have,
They're
it
only,
makes it really difficult.
yeah, they're just allocated for EP currently, and when we get few.
So are you having to dilute out, it's all the same vials of 1,000 and you're having to dilute them out.
Yeah, we pretty much have somebody that's there that's sole job is just basically that's in most cases.
And we've unfortunately had been doing this for a while, it's not just us.
Yeah.
No, it's a region issue.
And I don't think it would have changed anything in this case, I mean, if it's not gonna come back after a couple of shots. I mean, I don't, because I'm peds, I don't assume you could like once, but if it's not gonna come back with those first few shots that are delivered as quickly as possible. I don't know what the survival rates are to discharge after being in the ED, like other than electrolyte derangements that can be caught and treated in the ER. There's not much more other than continuing to shock.
Yeah.
I don't think it caused any harm, but it's just something to be mindful of and continue to remember as you're dealing with these drug shortages.
Yeah, and I do, I'm gonna agree with that assessment. I mean, back in the day, I mean, for those of you who have been doing this for a while, like, I mean, we used to give like 10 milligram doses of epi at a time. Like, it got some parts back in that situation, but on the balance, like, the long-term neurological outcomes of the situation, it's like, it's not go well.
Yeah.
Obviously, that's why we're doing the doses that we do. If you truly are having like, VTAC storm or refractory VFib, one thing you can consider doing is changing pad positioning as well. And I forget if this was an AP or if we did, our conventional, but you can always, especially kind of like anterior, posterior, if that's not the initial pad positioning, you can, put it in the traditional apical position of the pads, put a second one on, because once you take it off and put it back on, they're not gonna have a good stick. So, especially if there's like a lot of hair or sweat or body habitus or these sort of things, you can always, like I said, try a different set of pads and see if that vector change helps. There has been some talk about dual sequence. We're not quite there yet. The data is still probably mixed, but at least take some learning point from that and change a vector or change something is certainly reasonable. That said, refractory VFib and VTAC storm certainly happens. Sometimes it's related to a cardiac etiology, and so some places will put patients like this on ECMO. We don't have the capability anywhere near transport region and really even spottily to be broken down as a UCMC. I feel like it's some days that protocol is happening, sometimes it's not. So, and then sometimes, if the suspicion's really high enough, if like you get like a brief return of spontaneous circulation, and you get like very clear STEMI, depending on, the circumstances, sometimes those patients can go to cath lab. I don't think we've really done active cardiac arrest, certainly at Westchester, even downtown, when they do something like that, but theoretically you can think about things like that. But to be perfectly honest, like sometimes primary VTAC ends up being, the one, I had one a number of years ago, it was like a 30-year-old or something, came in with why in the world, turns out he had a big aneurysmal subarachnoid hemorrhage, like do all the epi you want, you're not gonna unfortunately reverse that course, they've already arrested. So sometimes that is, a different situation. So And especially with an ultrasound and showing cardiac activity, you can do what you do, exactly what you did, and then, kind of see if you're able to get some back.
Are you guys stocking calcium for renal patients? Yeah, so that would, history wise, computer. Oh, I didn't put this guy's age in here, I took it out with the kind of identifying information, but, if there's a history of, dialysis dependent renal disease, then the likelihood of electrolyte derangements, specifically hyperkalemia, is gonna be higher, and so calcium can be helpful in those cases, since you're sort of the only other med really
Yeah.
in your toolbox to throw at these patients. I don't know what this patient's underlying history was. I think he was a fairly old guy. If I remember correctly. But that's the only other med. That's all I have. If anyone has any questions or thoughts or feedback on, what was helpful, what wasn't helpful from this, absolutely let Chief Hartley know, let Dr. Richards know. I'm happy to kind of make this whatever is most helpful to you guys, and really get you kind of learning and feedback as best as I can. So thanks for your attention.
Thank you much. Cool.
Can I chime in just before everybody hops off?
Chime away.
Chime away. That's all right. Hey guys, so it's Lauren. We are doing a test of change at Westchester Hospital, and I know most of you have probably seen the QR codes and the kind of the memos I had posted in the EMS room and around the ED. So we are implementing a EMS timeout in our trauma base only for medical and trauma patients. So this test of change is basically to improve communication between hospital staff. You know how it goes sometimes. You call in, you talk to a nurse, or the phone gets handed off to a doctor, you give a report, and a lot of things get lost in translation. You show up to the hospital and there's 50 different people, including registration, nursing staff, physician staff, who are asking you to repeat your report. So we're hoping with the EMS timeout to kind of stop that game of telephone and for you guys to be able to be heard and have clear, concise information. So starting today, if you bring a patient into the trauma bay, you will hear one of our nurses kind of prompt a timeout for you. They'll say, we're gonna take this time to do an EMS timeout, go ahead with your report. Now you have a kind of an option to do a missed report, and I know this is kind of new to you guys and it's new to our ED staff. The missed report basically contains just information, the kind of the bare bones of what we want and need to know. If you aren't familiar with the missed format, please just give us a report as usual. It's basically just a pause for you guys to be able to give a report without interruption. What we'll do is you'll just come in, give your report with your patient on the cot, and once your report is over, we will then move the patient over. Now, there is certain circumstances where we'll have to move the patient over before that, but you'll be very well aware. Once we get kind of built into this test of change and it keeps going and we get more comfortable with it, if you guys want to learn more about the MIST format, I sent it to Chief Hartley in an email today. He can post it for you. It's posted all around our ED, and it's also posted in the trauma bays up on the wall, kind of as a reminder for you and a resource to help you move through with the report and the details of what we want to know. But new thing, it's new to everybody, new to our ED staff and new to you guys, but basically we wanted to help just improve that handoff and that communication. Does anybody have any questions?
Yeah, I think the biggest thing honestly is probably on the ED side of things, to give you all the time and space to do that. And then if the structured format is helpful, it'll be posted up there on the wall of the trauma bay. Honestly, the reports that you all give in the trauma bay are spot on. It really hits all these points, but if you need or want some structure to it, then that's fine. Dr. Cheatham actually has done a lot of research on this topic, like for pediatric handoffs, and correct me if I'm wrong, but I think one of the biggest things that I took away from your stuff is, hey, let's make sure that everyone is heard. So give this the time and space. Because otherwise, like you get interrupted, or you're not, the ED is not listening, and you have to go back and repeat it. It takes like 5 minutes to give the same information that left to you all to have your platform to give that you would have done in 30 seconds. So then everyone's, you know, kind of more satisfied with that interaction. It's better for the patients. So I don't know if that's you, if you have anything else to kind of add on that specifically. That's probably the biggest takeaway for me is the power of the ED to say, hey, let's give this time and space for this true handoff to occur.
Yeah, and being clear and succinct and kind of giving handoff in a timely fashion makes everyone happy. So however we can support that, promote that, that's what everyone wants.
So kind of just to summarize, the biggest changes you'll see is when you come into the trauma bay, whether it be for an actual trauma or for a medical patient, one of the nurses will prompt the timeout, and he or she may point out who the physician in the room is. At least they should be, at least. So you have kind of a person to direct the report to, but basically everyone is listening. We're giving you this time to give the report. We're hoping to keep reports in under a minute. 60 to 90 seconds would be perfect, but depending on the urgency of your patient, we'll kind of deem that report length. After you guys are done giving a report, whether it goes good, bad, indifferent, whatever, we have different QR codes that are outside of the trauma bay in the same places they were for that post data collection. Just scan it with your cell phone. It takes about 2 seconds to answer just a couple of questions. Let us know how we're doing, if this is something worthwhile that we should keep doing. We just want to make life easier for you guys. So just any feedback is appreciated.
And then Lauren, tomorrow's the trauma symposium. You guys are probably full, but are you doing
We
same
are.
day registration? Okay.
Yeah, so we are capped, but if anybody is dying to come, you can please send me an email, send me a text, and we'll see if I have any cancellations, or I'm sure I can work something out. Now, if like there was 50 of you that all of a sudden wanted to come, that would be a different conversation. But yeah, if you really want to join and you're off tomorrow, just shoot me a text or email, and we'll work something out.
Cool.
All right,
All right, thanks everyone.
thank y'all.